Bismillah ar-Rahman ar-Rahim. First of all, as a member of the Prince Sultan Conduit Chapter family, I would like to thank all the participants here for our conference. Thank you again. Let's start talking about the Conduit and the selection for CABG cases. Although it's the most common cardiac surgery performed worldwide, yet to date, no precise guidelines on graft selection exist. And the choice of revascularization strategy remains more a matter of art than of science. As we all know, the available grafts that we have, the internal thoracic artery, right or left, radial, and the saphenous vein, and to a less extent that we're not using actually nowadays, are the gastroepiploic and the inferior epigastric artery. The big dilemma, which conduit to select, and it depends, as my colleague previously said, on the patency rate reported on the randomized studies for each conduit, plus, and which is very important really, is the coronary anatomy itself and the degrees of stenosis of each of the targets that we're using, size of the vessel, patient comorbidities, age of the patient, and definitely the availability. Factors affecting the patency are the conduit type and, of course, the native vessels, the stenosis level. Arterial grafts are more affected than the venous grafts regarding the degree of the stenosis, and the patency rate significantly lower when functionally non-significant stenosis, and we have to take care of that, especially when we're going to talk about the radial artery, because it was the cutoff before was 60–70% stenosis. Now it's rising and jumping up to more than 80–90% stenosis to use the radial artery. Another important factor, of course, is the post-operative risk management with antiplatelet therapy. As we all know, the LITA, it's an old story. More than 30–40 years ago, it's well documented that it is the graft of choice for the LAD with approximately 90% patency rate after 10 years. It has less patency rate, of course, on the right coronary territory. And we should always use the LITA unless in emergency operations, and not all emergency operations actually, because we can use it in many of the emergency operations, only in the emergency where we have hemodynamic decompensation of the patient and we have to run on bypass. History of chest wall irradiation or radical mastectomy, proximal left subclavian artery stenosis, iatrogenic injury during harvesting, and insufficient flow due to small size. The right internal thoracic artery can graft RCA in situ, LCX in situ, and I use it, as Dr. Abdulaziz said before, through the transverse sinus. But it often needs to be used as a free composite graft to gain more length and to use it for more targets. Patency is not as good in the literature compared to the LITA, but I think it's maybe due to the non-LAD territory used with this LITA. For bilateral internal thoracic artery usage in the past 2 years, two independent meta-analyses have clearly supported that the use of beta significantly reduces the mortality rate with a follow-up of at least 9 years in each of the studies. And the major concern remains of the increased risk of sternal wound complication and mediastinitis. And one of the largest meta-analyses on this issue showed that adding a second internal thoracic artery to the primary internal thoracic artery to LAD significantly increases the sternal complications, and it's a fact that we can't hide it. To avoid that, as previously Dr. Hassan said, we have to skeletonize the internal thoracic artery, use the length only needed for that, spare the inferior epigastric, minimize cauterization, and tight sternal wound closure. Relatively, we should not use bilateral thoracic, internal thoracic artery in cases that we have risk of wound infection in obese, insulin-dependent, poor internal thoracic artery size of flow, moderate stenosis in the target vessels, and of course advanced stage. Now we're going to the dilemma of the radial artery, which was proposed by Dr. Carpentier in the 70s, and now it's coming back. It was reported that it has poor patency compared to Lita and Rita due to the vasospasm when it was first introduced, but now increasingly it is used to complete arterial revascularization. It's affected by calcification, intimal hyperplasia, and patency is especially poor in moderate stenosis. As we said, it has to be more than 80–90% stenosis, and we have to get it with an untouched technique to prevent its spasm. The Saphenous vein, historically, it's the most widely used. It's inferior to Lita, but comparing the Saphenous vein graft to radial artery and free Rita, in 1 year studies, randomized studies, there was no significant difference at all. But in 4 randomized controlled trials have compared the radial artery with the Saphenous vein graft. All the studies that extended beyond the first postoperative year showed clearly better patency with the radial artery over the Saphenous vein graft. And 2 studies, a tendency towards lower incidence of clinical events was also found with the radial artery patients. And number of meta-analysis. Pooled data from these randomized controlled trials, a large observational one comparing radial artery and Saphenous vein graft, extending beyond the first year, all showed benefits in the term of graft patency for the radial artery. The only meta-analysis to include clinical outcomes was found reduced cardiac death, myocardial infarction, and repeat coronary procedures in favor of the radial artery. Only there is one randomized controlled trial comparing the radial artery with the right internal thoracic artery, which is the RABCO trial. It found no difference in the patency between the 2 conduits and non-significant tendency to better event-free survival for the radial artery. And comparing radial artery and the radial artery seems to be a better choice for patients with the risk of postoperative sternal complications. Regarding the strategy when we're using the sequential anastomosis and Y grafting, we have, of course, as we know, the linear incision, and the diamond incision. We all know we have to do this to get more length and direction of our Y graft. And the third technique, which is the inverted diamond, and this is the one that I'm using in many of my cases, it gives a very nice direction of the Rita after doing the Y graft, which is the inverted diamond technique. In summary, Lita is still by far the best conduit choice for the LAD. Robust evidence suggests that the use of an artery rather than a vein to graft the second target vessel is associated with further improvement in the outcome. Retrospective studies seem to suggest beta offers advantage of single internal thoracic artery, but at increased risk of deep sternal wound infection. Radial artery is a very poor choice for moderate stenosis. In young non-diabetic patients, the aim of beta plus or minus radial on the left side and radial on the right if the lesion is more than moderate to complete the total arterial. And in older patients, still the Saphenous vein graft has a role. A recent despite all what we just said, a recent meta-analysis from the Society of Thoracic Surgeons database showed that till now, worldwide, slightly more than 5% of CABG cases receive a second arterial conduit, and we still go for Saphenous vein grafts. We may not be ahead of the game with invasiveness if we want to compare ourselves with cardiologists. We cannot compete with a puncture in the forearm or in thigh. Our target has to be longevity. So let's go arterial. Thank you.